My name's Emily Adams, and I'm a joint appointment between the University of Warwick and the Liverpool School of Tropical Medicine, which means I come down here approximately once a month for a few days to work in Mark's group. So really pleased to be here this morning. Up next to Mark is a tough act to follow, and I can't rap, so you have to bear with me slightly. Today I'd like to talk to you about simplifying molecular diagnostics for infectious tropical diseases. I'm going to run through two examples of infectious disease that we work on, LSTM, and visceral leishmaniasis and tuberculosis, and see the progress we're making towards implementing molecular tools. So slightly, if we're looking between the first man flight and walking on the moon, we're somewhere, I guess, in the middle of that. Things that we can actually apply now. So with diagnostics, I think firstly it's important to remember the types of diagnostics that we have, the different time points that we need a diagnostic tool, the different settings and the different interactions with patients that we have. So I think most people, when we talk about a diagnostic, it's a primary diagnostic tool for a symptomatic patient who's sitting in front of a clinician. For tropical diseases, this is frequently microscopy-based. If an RDT is available and suitable, then this is an appropriate time to use it if you use a tight clinical definition. And what I would like to talk about is integrated molecular tools. And when I use the term integrated, I'm talking about tools that require little management in terms of the training required for doing molecular diagnostics is very little, and it should be an integrated way of doing DNA extraction, amplification, and the readout and interpretation for you. But we do have different types of diagnostics. We have screening tests where we often sacrifice specificity in favour of high sensitivity because we will confirm our diagnosis at a later point. We have tests of cure or test of treatment response for pharmacodynamics. Serological tests are now inappropriate because they're detecting an antibody response which will remain high after treatment normally. And frequently, these are molecular-based tools used for clinical trials. We have drug sensitivity assays and we have epidemiological or research tools. Sometimes the tools span multiple areas and sometimes they can't. This has led to the development of multiple diagnostic assays, and sometimes the diagnostic algorithms can get quite confusing and quite elongated. But I think we must always remember when we're talking about development of diagnostics, what a clinician needs, what answer do they need. We don't want to overcomplicate a situation. We're also thinking about program managers, policymakers and researchers. What answer do they really require? At each point in each assay, the implementation should be based on evidence. Frequently it is not. And implementation requirements are often a neglected part of development of a diagnostic tool. So we really have to think about cost effectiveness, equipment requirements in terms of air conditioning, electricity, expertise, training required, and technological developments that may lead to the development and evaluation of simple tests are more frequently now molecular. So we try to work off assured guidelines which have been developed for diseases associated with poverty. Our diagnostics should be accurate, and that's in terms of diagnostic accuracy. They should have high sensitivity, high specificity. They should be user-friendly. They should be reliable and robust. We're often talking about situations in where temperatures can reach 45 degrees. A diagnostic tool might sit in customs for several weeks, months, so they should be able to withstand that. They should be end-user minded, and they should be deliverable. Not mentioned here is the cost and the invasiveness of your sample type and the evidence required for implementation. So really what I'd like to do is ask molecular diagnostics, can these ever be assured? So leishmaniasis is a spectrum of diseases, and I'll just quickly flow through this so that you have some understanding of what we're doing. This is a young child with visceral leishmaniasis, which is caused by Leishmania donovania infantum. It can go on to post-Kala-Azar dermal leishmaniasis, which is often a post-treatment kind of tail, we call it, from VL to PKDL, where the parasite moves to the skin. We also frequently talking about cutaneous leishmaniasis, which are different species of leishmania, and mucocutaneous leishmaniasis, which is when the parasite enters the mucosal system and causes, obviously here, very severe facial lesions. Why are diagnostics necessary for visceral leishmaniasis? Well, the treatments are extremely toxic. We're talking about the use of pentavalent antimonies, which for most diseases we would never think of using this anymore. It's a really archaic, they're arsenic-based, they're very toxic, and it's a 30-day course of IM or IV injections. The DNDi, the Drugs for Neglected Diseases Initiative, have a huge program of developing new drugs for leishmaniasis and other diseases of poverty, for example, trypanosomiasis. And they have come up with some better examples: ambizone, miltefosine, paramomycin. Miltefosine is the only orally available drug for leishmaniasis, but there are problems with this. It's tetragenic, and there are many cases of, let's not say resistance, but treatment failures in India at the moment. So the rollout is not going as planned. DNDi have quite a lot of clinical trials in terms of looking at combination therapies of these drugs. But specific diagnostic is is a necessity for VL, because we don't want to be giving these drugs to people without VL. So the available diagnostics, we've spoken about this a bit already today. Microscopy, this is our mainstay of diagnostic for VL. It unfortunately requires really quite highly invasive sampling techniques. So the splenic aspirate is considered our gold standard diagnostic for VL. But this is rarely performed, which is probably a good thing, and can only be performed when you have good access to surgical facilities. In its stay, we have lymph node and bone marrow aspirate, but these have lower sensitivity. And for example, in Ethiopia, people don't have parasites in the lymph node. In Sudan, they don't have parasites in the bone marrow. So there are some questions there. And we also have culture. There are serological tests available, and this is the direct agglutination test, which we used to produce in Amsterdam in the Royal Tropical Institute, where I've just moved from. And this does require some technical skill. You clearly require a microtiter plate. You dilute your sample down the plate, and this is a positive reaction with this kind of pale blue film, and the top are negative patients. So you can see here C, D, E, F and G are clearly positive patients, A and B are negative, and G you would really have a huge argument with many of the main players for VL. Everyone would get a different answer. We wouldn't know whether to treat this patient or not. So although it's got a high sensitivity and specificity, it's very subjective. There are a series of rapid diagnostic tests now available for VL. And some of them, for example, here in India, they have a very high sensitivity and specificity in a case control study. But if we move to East Africa and Brazil, we can see that the sensitivity drops hugely in terms of this is only 36%, and the same happens in Brazil. We're not sure why. We don't know if it's parasite diversity or immune response to infection. Anyway, there's clearly a diagnostic gap, especially in East Africa. So the molecular diagnostics, all this genomic information that we're now getting out, can we use this to produce good molecular diagnostics? Well, recently we did a survey, a systematic review of all molecular diagnostic studies that have been published. And we pulled all the sensitivity and specificity values across the board for all of the studies on molecular tools. The most number of studies was a PCR performed on blood, and here we have 19 studies, and if we pool all of our patients, then we get a good sensitivity of 93% and a good specificity of about 96%. I hope you can read that rather small. So this is good. I mean, we don't think that parasites are in the blood as much as in the kind of systemic organs, and so a sensitivity of 93% is actually pretty good, considering that we're taking a non-invasive sample. If we move to the bone marrow, then the sensitivity does increase. The problem that we found, and really this is an ongoing discussion with colleagues, is when we look at the consecutive studies, so when we're looking at visceral leishmaniasis suspects rather than case control, is that although our sensitivity remains high, our specificity drops to 63%. Now, is that because our test is more sensitive than microscopy and we're picking up more patients, in which case we would expect a higher sensitivity than 92%? Or is it that we're picking up degraded DNA, we're picking up transient infections, we're picking up people who have a VL infection, but that's not the cause of their disease? This is really interesting, and if you have any input, I'd be very keen to hear it. So that's where we are with the molecular tools for VL, but they do show promise. They are of high sensitivity, and maybe it's possible that some of these studies, there are very few studies, only 4, so maybe they haven't performed as well as they should. So I'm a consultant for the Foundation for Innovative New Diagnostics, which is a product development partnership in Geneva. They work on, they're really I guess, a PDP that looks at new technologies for diagnostics and which ones, they're kind of horizon spotting the best of these technologies, and they're moving them forward into diseases for poverty. So LAMP is one of these molecular assays, which is, I guess, a simplified version of PCR. It works on the basis of 6 primer sets designed on a conserved region over 200 base pairs, and it's an isothermal reaction, so it's working at 65 degrees. It uses one enzyme, which is possible to freeze dry, so it's a quick 40-minute reaction. It's isothermal, so it's at 60 degrees, you don't need a thermocycler, and importantly, you have a visual readout. So it is a more integrated PCR system. FIND have developed a LAMP kit for tuberculosis, for malaria, for trypanosomiasis, and we're working with them for leishmaniasis, and they're also producing one for Chagas disease. Here you can see the kit for Trypanosoma brucei. This is the reaction tube, and in the lid you can just see the kind of orange stain of the freeze-dried reagents. So all you do is introduce your DNA sample into the bottom of the tube, you close the lid, you shake it up and down, you put it at 60 degrees for half an hour, 40 minutes, and you can visually read out whether you have an infection or not. And so here's that positive reaction and the negative, and it's very clear, and they get good sensitivity and specificity values and good technician-to-technician agreement. So we're working on this for leishmaniasis, and it's going very well. I can't give you any results because they're all with Icon, the company in Japan that produces them at the moment, but what we can say is that they're similar to the qPCR and PCR results that we get, yet this is a much simplified system. What is now really important for us is to look at sample processing. So if we require a full DNA extraction, there's no point having a simplified amplification, because therefore you need a well-equipped laboratory. So we're looking at simplified sample processing. Just a little bit on how we produce the primers, just to get my genomics in here, is that we did a whole genome comparison of 10 of the kinetoplast genomes. So our challenge was to find a conserved area of 200 base pairs for all the leishmaniasis species, and there are more than 20 of them, but that did not have any cross-reaction with the trypanosoma, which are very similar genetically parasites, and had an extremely high copy number. So this was our challenge. Here you can see other people in the audience will be much better able to analyse this than I would, but you can see areas where we have agreement between the leishmania and not the trypanosoma. So we went through a huge number of target identification, and we only found very few that had a high copy number. So that's really been our challenge. But we have done that. We have got primer sets, and we are in the process of evaluating these primers. At the moment, we can detect with our kDNA target and about 1 parasite per mil, which is really little. And with our 18S ribosonal DNA, we can target about 10 to 100 parasites per mil, because it's a lower copy number target. So at the moment, I just come back from a trip to Ethiopia, where we are enrolling 200 visceral leishmaniasis suspects. They are undergoing the normal gold standard diagnostics, so that's a splenic aspirate, or here this is El Miestiro, the clinician in charge, performing a bone marrow aspirate, which he has to if they're not able to perform splenic because of low platelet count, for example. So this patient is a VL HIV co-infected patient. They come in, they're extremely thin, and they really need help. So we're performing a head-to-head evaluation of the molecular test, the serological test, and a new antigen detection system that will be performed in the urine with FIND. So I'm going to change tack slightly to move on to tuberculosis, where a lot more investment has been made in molecular diagnostics, in their development, in their evaluation, and in their implementation. They're a lot further along the track than any of the other tropical diseases. And I want to talk to you mainly about a recent success story in molecular diagnostics, which I'm sure most of you have heard of. This is the GeneXpert produced by Cepheid. So this is totally integrated DNA extraction amplification device. And here is the cartridge where you introduce this sputum to a buffer. It's warmed, and then it's put into this cartridge, and then the cartridge is introduced to this unit. And 2 hours later, it will give you a yes/no answer on TB infection, and they also amplify some resistance markers, so it will give you an idea of whether your patient also should require MDR treatment rather than the first-line treatment, so it has a resistance marker for rifampicin. This has been, GeneXpert was originally designed after 9/11, so it was Cepheid are an engineering company in America. After 9/11, they decided that really they wanted a diagnostic test, let's say, that they could put into post offices, that people working in a post office could swab envelopes, that they could have an idea of whether they had any anthrax contamination. So it had to be virtually zero training. So that was how it was originally marketed, and now they have multiple cartridges for MRSA, HIV, TB, syphilis, but they're not going to make it an open platform. They're not going to say, have you got your own primer sets, we'll introduce them to a new cartridge. So it won't be available, at least in the near future, for VL, for TRIPS, for malaria even. And there are concerns. There is quite a high initial cost. difficulty in the sustainable supply of cartridges, and when the funding agency pull out, what will happen then? You know, there will be lots of machines. Will governments, will ministries of health be able to afford the cartridges? And it's only really suitable for settings where you do have some infrastructure. It's not point of care or near patient care. It still requires a room, air conditioning, continuous supply of electricity. But in Ethiopia, in the same lab where we're doing our VL evaluation, I'm not sure if you can see this, but this is their GeneXpert, and if you can just see on their computer screen, it says they're Cepheid, a better way. So they're very pleased with what they're doing, and they're very enthusiastic to go forward with these molecular diagnostics. So there's been a lot of interest in GeneXpert. The Cochrane Collaboration for Infectious Diseases is housed at LSTM, and they've recently produced a systematic review so that GeneXpert could go to the WHO STAG committee, where it was endorsed a couple of years ago, and they can roll out this diagnostic tool. And I won't go through all of this. This is the abstract for the systematic review. But the things to note is that with smear-positive TB cases, GeneXpert is about 98% sensitive, and with more importantly, with smear-negative patients, it's about 70% sensitive. LSTM have been quite heavily involved with the rollout and implementation of GeneXpert. Louis Cuevas is one of the professors and a clinician at LSTM. He works in Nigeria, where the community health workers have identified 3,000 symptomatic adults in Abuja. They've performed smear microscopy and GeneXpert simultaneously, and they were able to increase case detection by 70%. Most cases were identified by both tests, by both smear microscopy and GeneXpert, with GeneXpert having that additional yield on the smear negatives. They actually concluded that this was of limited value, as you were wasting a lot of expense and the cartridges, etc., and transporting of all the samples to where the GeneXpert had been implemented. So rather, in Ethiopia, where they identified 40,000 symptomatic adults at home with the help of with health extension workers. And here they tested everyone on smear microscopy, and on the smear negatives, HIV patients, and on children they did the GeneXpert, and here they were able to increase case detection by 200%, more than 200%. And this is likely to be adopted by their national programme. There are some caveats. The cost of GeneXpert, the machine, a 4-module unit, costs $17,000, and the cartridges have just been reduced from $17 to $10 per cartridge, which are single-use, one patient only. But there is huge enthusiasm for GeneXpert. 1,400 GeneXpert systems, comprising 7,500 modules, have been implemented as of June 2013, and over 3 million GeneXpert cartridges have been procured by 88 of the 145 countries under concessional pricing. The cost is estimated to be similar to that of running microbacterial culture, with clearly less training and infrastructure requirements and less time for results. Louis Cuevas is actually at the moment preparing a manuscript based on the hidden costs of GeneXpert in Nigeria. They concluded that districts that did not need much upgrading, in that they already had some laboratory infrastructure, it took about an extra $2,000 to clear customs, to transport the equipment, to have security of the machines, etc. But centres that required more space, the cost increased to $10,000. This is a really high hidden cost of implementing a machine such as GeneXpert. And most of that was that in the end they had to buy those kind of shipping containers so that they had space that they could put the GeneXpert, the computer, the air conditioning, the backup generator, etc. So there is hidden costs. Even with those extra costs, it does not include the running cost, the cost of the storing of the cartridges. Should I stop? And the wastage of the cartridges. So I think there's only a 9-month or 12-month you can only keep the cartridges for 12 months. And WHO recently calculated that one machine running at 75% capacity would cost about $100,000 per year. So at the moment, GeneXpert is located at district hospitals, and we think we probably need something that's more suitable for diagnostic centres. In Nigeria, GeneXpert Nigeria will have 180 machines by the end of the year, but they have almost 1,500 diagnostic centres. So clearly, these figures don't match. And even worse, the number of diagnostic centres is less than half the one centre per 100,000 population recommended by WHO. So, are there any alternative solutions? Well, there are lots actually. There is a huge number of different PCR platforms, integrated lab-on-chip systems that are being developed, and companies can now see with this huge enthusiasm and rollout of the GeneXpert that there's really a market in producing these types of systems. One that we are currently looking at is by Epistem, which is a company based in Manchester, and they have the GeneDrive, which is a CE-marked product. It looks a little bit like an iPhone. It's handheld, portable, can run off a battery, can run off a lighter in a car, and it's a similar idea in that it's a cartridge-based system which is single-use. You can have TB yes/no. You can have an idea of rifampicin resistance and internal controls in this single cartridge, which is plugged into the system, if you can just see there, and in less than 2 hours it gives you a result. So it's now being released for TB. They have plans to develop more cartridges for malaria. We have some concerns. There's no quantification of pathogen load. It's a low throughput technique because you have one, but then it's more portable. You could see them being pushed out into more rural areas than the GeneXpert. So we have a plan to start working with Epistem to start the evaluation of GeneDrive for TB in Nigeria, because we have a good centre where we're working. So again, watch this space. And that just leaves me to thank all of our collaborators that worked today and Mark for inviting us along. Thank you.
Sorry for the interruption.
No problem.